All right. Welcome to Carolina Health Center's podcast, Access Matters Beyond the Exam Room, where we talk about health, community, and how we take charge of your well-being, one step at a time. Today, we're diving into something that might seem simple, but is truly powerful: primary care, especially at your local community health center, us, which is also known as an FQHC. And we are also specifically going to transition into the importance of behavioral health integrated into primary care and how that is a thing we do at Carolina Health Centers, and we do it very well. Thanks to our Director of Behavioral Health, Jessica Jacobs. I also have the Director of Family Medicine, Braye, Dr. Lance Braye here, and I am Rachel Manor, Director of Development. So without further ado, I'm going to, wet your whistle. I'm going to start this first segment off with, and you know what, this can go to anybody, but we're going to talk about what is primary care and why it matters, why it's so important. So in plain language, what is primary care?
Well, I always think when trying to explain primary care, it's a lot like the famous Gordon Ramsay clip when he's saying grilled cheese, the recipe's in the name, right? Primary, the first one. And so the way I could really try to explain to my patients sometimes what we are as primary care is we're really like the quarterbacks of the healthcare team, right? Like as soon as that play starts, the first person, the primary person the ball gets to is that quarterback, right? And every now and then you might need specialists, so might have to throw a pass to a cardiologist, wide receiver. You know, you might have to hand it off to a gastroenterologist, running back. But everything really centers through the quarterback, and a good quarterback knows what everyone on the field should be doing at all times, right? And so that's really kind of how I like to explain primary care, to be that approach to where if I'm your PCP or primary care provider, in my case as a doctor, primary care physician, then what it is I'm kind of your first point of contact into the healthcare system. And you need to get your physical done. I got you. You're sick. I got you. You take medication for whatever reason. I got you. And every now and then something may happen that you need something done that I do not have in the office or I don't have the skill set to do. Like, I don't think you want me taking your gallbladder out. I know how to do it in theory, but it's on you if you decide to let me do that, right? But so in that case, then we will hand it off or pass the ball off to one of the specialists to get done. But then even there, when they put you on new meds or start you on new things, if I'm doing my job right, I should know what it is so I can explain it to you. So very often when I am not directly taking care of somebody in something as their primary doc, I'm kind of doing that translation after the fact where they come as like, I don't know what that guy says. Like, it's okay, I got you. And we read through the notes together and figure it out.
Okay, awesome. Now, in a curling metaphor, can you explain it? No, I kid. Do you have anything you want to add to that, Jessica?
So when folks notice anything that's wrong, the first place we go to is the doctor, right? So whether that is individuals who have a concern that's a mental health concern, right? Or a medical concern, right? It is just the first point of contact. And so a lot of times, especially even if we start talking about behavioral health, it's where you get a referral to behavioral health as well. So it's just that first point of contact.
Awesome. I love that. So you talked about common services and checkups and chronic disease management, vaccine screenings. What is the importance of a long-term relationship with your provider? Because as an FQHC, we want to create relationships with our patients to better serve them, to get that comprehensive view of who they are, what their lifestyle is, what their families might be like. So to add to that, what's the importance and the impact that a long-term relationship can have on a patient?
Yeah, I think that relationship is a big reason a lot of us decide to do family practice in the first place. You know, like I love the fact that I could take care of you and your kids and watch your kids grow up and then be there with them now I'm taking care of their kids and your grandkids. And really you get a familiarity with somebody, you get not just know their medications and their medical problems, but really who they are as a person. And you're kind of, the way I see it, I'm kind of a different doc for everybody because somebody might need someone that just is going to listen because they are not going to take my suggestion of a behavioral health referral and go see Jessica. So I was like, great, I'll be your bootleg therapist. Here we go. And then we have other people that they need me to be more of a teacher, to really break down like, okay, what is this diabetes thing really? Like, what does sugar have to do with any of this? Some people just need me to understand that they're going to do whatever they want to do. And I just kind of give them their best risk estimate on it. Like, well, you want to smoke? Just let's just talk about what's coming if we decide to do that. And so I really love it. But for the patients, I think it's really something special to have someone that truly knows you. Having to move around a lot, just coming up through medical training, I haven't had the opportunity to sit with like one doc through all the years. But to me, in the way I see it, it reminds me a lot of like my teachers, my mentors, my coaches that I still stay in contact with from like high school and college, to where it's like they know me and they know how I am because they've seen me in the good, they've seen me in the bad, they've seen me in the ugly. And so you just have that familiarity with somebody. And I think it's really that biggest thing is that familiarity, because medicine can be scary. There's a lot of moving parts, and it's good to have a familiar face that is like just there with you.
Okay, awesome. So it's not just about when you're sick. It's about staying well, having someone who's with you every step of the way. Yep. And I've heard you say this before, and I loved it. If you're doing your job right, you don't have to see patients.
Yeah.
Right? Like you hypothetically.
Twice, 3 times a year.
Right. Yeah. If you're doing your job and they are also doing their part, right? That's the other very important piece. Then you wouldn't have to see them that often. Right. And so just to kind of in the same vein, I'm going to kick this one to you, Jessica, because I know you have a lot to say about this. Well, no, I just mean because you're a champion for FQHCs. So just in plain language, can you explain what an FQHC is and like why it's different?
Sure, absolutely. So actually, when I got hired by CHC, and I am always somebody who I do my research when I get hired. And so I had heard community health center, community health center, community health center. And about 2 weeks into being here, somebody said FQHC. And I was sitting in the large conference room and I said, oh, what is that? And then when they explained it, I was like, am I fired now? Do I have to go? And so the more that I've learned, because I didn't know what an FQHC was before being here, right?
Right.
Right. But an FQHC is for everyone. And that is what is amazing, right? Because there is no prerequisites to walk in the door, right? And so we serve from womb to the tomb, and we serve any socioeconomic status, right? Any background, any, because the other piece, and I'll tie back to this really quickly, because Dr. Braye was talking about, I know my patients. Well, also you get to know the family culture too, which is so important, because how does this family access and interact with the healthcare system? And so knowing that if you are seen by a different provider every time and there's no collaboration, they don't know your family culture. And so sure, I tell people this all the time, I can make the best behavior modification plan, but if it's a behavior you don't want to modify, it's not a good plan.
Yep.
And so with an FQHC, it's a federally qualified health center that really encompasses whole person health. And so we treat folks who are babies, and we educate parents on, what services do we need to best support healthy, happy development. But also we see pediatrics, and we see behavioral health in pediatrics. We have early childhood services. We have our own pharmacies. We have our family medicine. Like there are so many services, and there's nothing that we can't at least respond to, right? So we may not be the folks that stay with it from a treatment perspective, but we respond and then we refer out, and we still keep a line on that, whatever it is we're treating. And so I think it's the best choice if you have the option of accessing it, because you're getting excellent care without some of the needless overhead, actually, that you may find in another setting.
Sure. And because we live in acronym world, sometimes these things can roll right off of our tongue. And so I know Jessica mentioned this, but FQHC stands for Federally Qualified Health Center. Sometimes people hear the word federal and they think, oh, you're funded by the government. We are not. We just check the boxes to be considered as such. And then once we are considered an FQHC, we are allowed to apply for certain grant funds that help us offset costs of serving underinsured and uninsured patients. But we see everyone. So just to clarify that for anyone who is not 100% familiar with FQHCs, again.
And I'd like to...
We live in acronym world, please.
Oh, yeah, and just to reiterate that part about we see everybody, because a lot of times I tell people this and they think, okay, so you see like kids and adults, like, well, yes. Like, what about my insurance? Like, bro, you can have full insurance, half insurance, no insurance, peanuts in your pocket. I don't care.
Yeah.
Come on in. I'm going to take care of you. And that is something that I think we kind of talk over, but like that is such an amazing thing.
Mm-hmm.
Like, a lot of us on the provider side, and for like medical and in mental health as well, right? Like how many of us, if we were working under another system, would have patients that we love.
Yeah.
And then you find out they ain't got that insurance no more. And then you would like to keep seeing them.
Mm-hmm.
But your boss in finance will be like, don't you dare. Right?
Mm-hmm.
So it's like,
Mm-hmm.
love you, but I don't have to do that being part of a fairly qualified health center. And so you could come in, everything's going great, you can lose everything, and I'm still there with you.
Absolutely.
And that is something that I think in just the U.S. healthcare system is not common. And that is something that is a real big strength of being in an FQHC,
Mm-hmm.
to know that you just have that security.
Mm-hmm.
You don't have to choose between be healthy or feed your family. It's you can do both.
Yeah.
And we can help you with that.
Yes.
I think the last thing that
Please.
I'll say, right, is because, we think like, oh, okay, well, you see everyone. So is it discount services, right? And it's accessible, affordable services with highly qualified and well-trained staff. Right?
Because since we received that federal funding, we have certain standards we are required to meet that maybe some entities are not required to meet because nobody's watching them and how they spend certain funds and what they do with them. And so we are required to maintain a level of care that is accessible to everyone. And so the same high quality care that someone with insurance receives, someone without insurance is also receiving that same care.
Yeah.
And so that's what's super amazing. And I've worked here for 12 years, and I will work at an FQHC until I die. All right, so we talked about this, womb to tomb, right? I'm taking it to the tomb. We talked about, you mentioned, speaking of womb to tomb, the whole person, treating the whole person. And FQHCs have this really amazing way of, as a foundation of primary care at the base, finding out what the community needs and creating the programs, the supplementary programs that are also tapping into the other needs. And that can be dental, that can be women's health, like specific OB/GYN services. We have an early childhood services department. We'll do another podcast on those at another point. I think I mentioned behavioral health. And so to bring into that we have integrated behavioral health into primary care, and a true integration, not just co-location, but a true integration. We have, I was talking to a woman whose child goes to one of our pediatric sites, and she said that she experienced the seamless moment of her 13-year-old son being asked, for it was just a well visit. And the kid had filled out a checklist or whatever. And he had said that he had experienced anxiety. And that seamless moment of where your primary care provider says, oh, I see you checked here that you have some anxiety, you have some issues, or not issues, but you have some moments where you're experiencing anxiousness. I'm going to send you across the hall to talk to so-and-so. And it's right there. It's not, you need to go to this place. We have to see if they take your insurance. You have to wait. It's not affordable. It is right across the hall. And that is, I think, absolutely invaluable in the climate that we are in right now, because I've heard people say it, but it's like we've been divided from before COVID and after COVID, right? Like we're not the same people. And I think we're just now starting to see some of the impacts that had on everyone, but especially youth, and some of the long-term effects maybe. But to speak on that, to kind of transition it into behavioral health, Jessica, what is behavioral health and how is it different from mental health?
Sure. And some of this, it will depend on what practitioner you talk to, right?
Sure.
But in general terms, when you think about mental health, you're thinking about those, how I term it, is like the proper mental health diagnoses, right? So when you think of major depressive disorder, generalized anxiety disorder, post-traumatic stress disorder, schizophrenia, substance use disorder, you're thinking about a lot of times those very traditional mental health diagnoses. However, when you add behavioral health to the conversation, now it's a game changer, right? Because it used to very much so be if you have a concern above the shoulders, oh, well, you go over there and talk to that counselor, right? If your concern is below the shoulders, oh, well, you can talk to Dr. Braye about it, right? However, now it is, there's no magic height. Okay.
There's not a cutoff line
no,
somewhere.
there is not, right? And so when we talk about behavioral health, we're talking about all of those aspects because stress isn't a diagnosis, right? Nobody's coming to me and I'm saying, oh, yes, they have, this code and it's just stress. Nope. So what we're talking about with behavioral health is that impact of the social system on the person, their environment, right? We're talking about a lot of substance use. We're talking about mental health. And so we're talking about a lot of the intangibles that haven't always been recognized in the way that they need to be, but have always been a part of the conversation. Honestly, for providers, always.
Yeah.
We just couldn't bill for them, right? And so we were still treating them.
Sure.
We were still addressing them because no patient has ever come into my office and told me that, well, we can't afford food. And I've just said yes, very sad.
Sure.
Right.
Sure.
We've always been attending to that
Trying
and saying,
to meet the
okay,
need.
let's see, where can we put this resource in place, right? What community partner can we connect you to? Well, but now we're talking about social drivers of health as well, right? And so that plays into and impacts behavioral health because if you're worried about, summer's coming up, and so people are going to have to start making some really hard decisions about how many meals can their family eat a day because we could rely on school for 2 of those, right? And so, and a lot of the school districts are doing great programs, right, with helping to meet those needs. But we're talking about all of those things that impact our health and wellness.
Okay. So can someone be mentally unwell even if nothing seems physically wrong?
How in the weeds are we getting, Rachel?
Yeah.
I mean, how in the weeds do you want to get, Jessica?
So, I think I'll answer that yes, right? Because for years, we did not talk about it, right? And so folks are coming in very unwell.
And when you say hit me with a list of the basics. I mean,
sure.
Yeah.
So,
what are people experiencing that you see most of?
Absolutely. Actually, so I pulled some numbers recently, and it's from 22, just, because again, we all know data lags, right?
Yep.
Consistently, the most prevalent among, and we'll say 18 plus in the United States, it's anxiety disorders, depressive disorders, substance use disorders, co-occurring disorders. And so co-occurring, I mean a substance, folks meet at the same point in time, the threshold for a mental health diagnosis and a substance use diagnosis.
Okay.
Now,
so they have depressive disorder and substance use disorder.
Absolutely.
Okay.
Yep.
Got it.
And so now, that those a lot of times are the top 4. But when I talk to folks, there hasn't always been this clear education, right? And so you'll hear people and they will throw out diagnoses that perhaps have gotten more traction in media.
Okay.
They've been really sensationalized, right? Okay. And so, they'll think of maybe a more serious mental illness and maybe a really stigmatizing and stereotype way of it presenting, right? Okay. But now we're talking more and more about diagnoses that 29% of Americans 18 plus in 2022 were diagnosed with generalized anxiety disorder. 29%.
Yeah, that's almost a third of us.
That's a lot.
It's one of us at this table. You know what I mean?
Absolutely, right?
Yeah.
And
those are still only the people seeking help.
So that's exactly it.
Right? So if the data says 30 is more.
Yes.
Wow.
And I think too, when you think of what contributes to it, right? Sometimes when I lay it out for patients, it's why would you not be struggling with what you're going through right now? I mean, if everybody drank 5 gallons of sweet tea every day and the stat was only a third of people have diabetes, we'd be like, I don't know about those numbers. Did you check everybody's blood sugar?
Sure.
And I think with mental health, it's the same. I mean, so many different communities was just what what, just like you said, after COVID, why would any of us be okay? Like, why would we be okay? Why, how am I going to be okay? Or anyone that was in healthcare during that time? How about the folks that, lost family members or like almost lost their
and
own
didn't
life
get
because
to
of
like
it? Yes.
feel closure.
Yeah. Or just, the existential sense of dread that just permeated throughout that year in history. And so like, and if you think that anyone's going to come through that or any of the other terrible things that happen in life, people that used to, serve in the military are still actively serving, first responders, just, living in a city with people or living in the country where there's no one there and you don't have the resources, like, it's okay that you're not okay.
Right.
And I think, to help Jessica do her job, and it's really big on the folks on my end to also just normalize that. Because we got real normalized to talking about your sugar is really high. You might need insulin or your blood pressure is really high. Stop smoking or whatnot. But we need to normalize like, yeah, you're struggling. I get it. And that's fine. We're going to help you out. And I have one of the world's best therapists here to get you through it.
And she's got an amazing team.
Yes.
Also.
I do.
So then to bring it kind of personal to the Greenwood Lakelands area, because that's who we serve, are behavioral health services easily available in our community, besides what we're already doing, obviously, but as a whole?
Sure. Well, if we put it in perspective, so again, Rachel said we love acronyms, and we do,
We
right?
do.
So HRSA, or Health Research Services Administration, does a health provider shortage area assessment.
Of course they do.
Right? So a HRSA HIPSA score, it's very exciting.
HRSA HIPSA.
Okay. So that goes up to 26. And the higher the score, it's so good.
Right.
It is not good.
It's one of those reverse scoring systems.
And so our entire service area in primary care, our score is a 19. Okay. But if we isolate that into the specialty that is behavioral health, that score increases from a 19 to a 23.
Yikes.
So when you say, are services widely accessible? No. Does that mean there aren't any services available? No, not at all, right? What it means is we need more. And so we're in a health provider shortage area, and it means there might be a longer wait time. It means that cost may be a factor depending on where you are and what providers are actually in your area. And so we don't have all of the resources we need, but there is a big focus on how do we use the resources we have in this area.
Okay. And this is a sensitive additional question to this, but how do race, culture, and income level influence access to healthcare? Because we know, we're rural, okay? And so this is really everywhere, but all across, if you're talking about socioeconomic levels, like you see it all, right? It's all across the board. And so how are these things influencing access? Race, culture, income.
Sure. When we think about, do your providers look like you? Do they understand?
We were talking about this earlier.
Yeah. Right? Do they understand the culture that is your race, your ethnicity, your income? Do they understand your way of life, your family, right? Because again, delivering, Dr. Braye and I did a presentation actually, or we both presented at another event, and we were talking about rural healthcare delivery is different from urban healthcare delivery. It's not that the science changes, but the application sure does.
How?
Right? Ooh.
Give me pick top example. I know there's a multitude of ways.
There are. One of the things that I think of is you have, especially in rural areas, there is very much this idea of like, we are not going to air our dirty laundry. We are going to pull ourselves up by our bootstraps.
Yeah.
Thanks. Right. And so, especially for behavioral health, what that might look like is a warm handoff into Dr. Braye's visit multiple times before they ever schedule an appointment for me.
Gotcha.
And to be perfectly honest, that may look like a patient never scheduling a behavioral health appointment, but I might come into every single doctor's appointment they have.
Okay.
Because there is an element of stigma that still surrounds behavioral health as opposed to the medical side of things. And that's one of the myriad of benefits of embedding behavioral health into primary care. Because I always tell folks, if you park in our parking lot and you come inside, nobody knows if you're here for bunions or bipolar, right? There is no difference in how you're roomed. There is no difference in how your name is called.
New marketing campaign. We got you bunions to bipolar. You heard it here first.
Yes.
I love it.
It's an original even.
I love it. We'll trademark it. I will give you credit. Oh my gosh.
But it helps to reduce stigma. One of the things I talk about is I could tell you right now, and I won't drop their names on the air, right? But I could tell you the makes and the models of some of the cars that I went to school, like high school with, right? I'm from a very rural area. And so if they're parked outside of the whatever clinic,
sure,
I know exactly who's inside, right? And so we have to think about that in a rural area, whereas in a more populous area, there is public transportation, right? Or there's 17 red Cavaliers, right? It looks a little different.
Sure. Yeah, go ahead.
Ours, I think the race, culture, the income, it impacts everything. And then it gets tricky, right? Because like one person's experience doesn't speak for everybody's, right? And so whenever talking about this, I just like to throw my dirty laundry out there, if you will, right? Like I struggled with anxiety in medical school, and that was something that was really hard for even me as a medical student, as someone who came from a family where like we're familiar with healthcare. My mom's a nurse. I guess you could say middle to whatever regular middle is, middle class, I guess, to upper middle class. Like you would think like, oh, well, this guy's have it. But no, I only got involved with therapy because like my study partners this one day was like, you're going to student health right now or I'm dragging you.
And that's the importance of having friends like that.
Yes. So I was like, no, I'm fine. I'm okay. Okay. She's like, you're not okay.
You're
like,
not okay.
She saved my life. But when you really look into it, I think it, just for me in that case, like, okay, one, just as a man, why am I going to like acknowledge weakness, even though it's not a weakness, right? But just the way I was raised was just like, no, like if you ain't bleeding,
man up,
still walk, get out there and keep going, right? Like, oh, you're stressed, suck it up, keep moving, right?
Right.
And so there's that piece, or then also just like in my experience as an African American, like historically, what happened to us if we had any kind of mental health stuff? Or just interacted with any like formal system in the first place.
Well,
right?
and I feel like
seeing your family anymore.
Well, and there's a culturally learned, ingrained distrust for a lot of things. And then back to your point a second ago about cars, makes and models. One of the things that we found, and I know that the ID, our infectious disease department, falls under our behavioral health department. That is also a piece of our integrated into our primary care, but a piece of that is there are still people who travel outside of our service area because they're worried about who they're going to see.
Correct.
And it might, if it's their mom's friend, and then their mom's friend goes to their mom and is like, oh, hey, I saw Jimmy at the doctor's office. What's wrong with him? And it's like, well, the mom didn't know. And so the mom's asking, and now everybody feels like everybody knows stuff. And so it's that small town thing.
Absolutely.
And then the generational just upbringing, if you will, of man up, you deal with it, you whatever. And so
like our spiritual backgrounds, right? Like,
yes.
I'm a church going guy. And that was harder than I anticipated, like just telling other people from church and stuff like, I'm like struggling with this, right? Because like, and that's a whole nother podcast that we could just save for later in the schedule. But just
we might not dive all the way into that one.
But I think it's one of those things. But I always like. But I love thinking about that and talking about it, not just because of stuff that I've gone through, but I think a lot of times this kind of blame game where we say like the patient didn't want to do this, or they decided to keep smoking, or this, that, and the third. But it's just like, but did we do our job to explain to them? Because I think sometimes we talk about how like race and class and upbringing all brings into it. There's the whole, have you ever heard of like the whole concept of like the white man's ice?
Ice?
Yes.
Ice? No. Okay. Please.
So I can't remember where I picked this up at, but basically it's this thing to where you would think if you're from like a marginalized group, sometimes it kind of becomes this thing where you expect that whatever the other group has is better than yours because you always get the less, right? Like you literally, as Black folk, would think like the white man's ice is colder. And
Got it.
I think I see that, and I feel like I see that in healthcare a lot, to where sometimes it's like, you know, especially in rural areas where it's like, I could go to this doctor's office or this hospital that's literally right here. Or I could go an hour to like the city up the interstate or up the highway because they are better. Right. And now, again, because I'm always totally ready to like, you know, take our blame in it. You know, sometimes we give them reason to believe that yes, they probably are better. But for me, you know, it's, you know, and like I tell my providers all the time, like I am trying to outperform all the big boys.
Right.
And I'm not going to go and give their names right now. But like,
Forever.
Yeah. You know, no, but I mean, but my thing is like, no, like if you're coming to me, my goal is to be the best daggone family doctor that ever existed.
Absolutely.
And I hope all my providers have that same mindset. And so, you know, we need to get to a point to where what you have here is just as good, but we also still have to acknowledge, like, even if we had that distinction, if the governor came in and said, this is the best place ever, that some people will still want to go to Greenville or go to Columbia or all the way down to Charleston, just over to Atlanta, because there is that piece, because historically, what have we given to folks out in the country? You know,
less.
Yeah, exactly. And so that whole thing, I think we just have to be cognizant of that, especially, you know, when it's your own race, culture, income level, but also understanding when it's others and understanding that you're never going to be the expert on something. I'm a family doc that loves to do women's health. And, you know, and I've told, you know, multiple times, like, I am not about to sit here and tell you what it's like to be a woman. Like, it's like, you can't do that. So it's also us having to have that cultural humility, which is, again, something that you do see more in FQHCs, because FQHCs are in those areas where folks have been downtrodden for so long. And so I tell, like, my students all the time when they come on, it's like, this is some real activist stuff we're doing around here. Okay? Like, this is not just a doctor's office. Like, we're changing the world here. And I think because we do take into account all of that and how it plays in, whether that's their medical or their mental health.
Because we have to acknowledge that the psychiatric and medical communities have not always interacted with the appropriate respect and ethics with every race. Like we have to acknowledge that.
Right.
And now, again, I'm really proud of my colleagues, right? I'm really proud of what we do. And if I say, oh, well, you know, we don't do that here though.
Right.
You know, I just completely invalidated this concern because the truth, like the history does show that. And so we have to acknowledge it. And I think that's the other piece as, you know, as a behavioral health provider, right? It's okay to acknowledge the uncomfortable.
Oh, absolutely.
It is okay to acknowledge the things that we wish weren't accurate or weren't historically true or aren't still true some places, right? And so we have to say, you know, I see and I hear what you're saying, and I'm going to respond to that in the moment. And so whether that means I actually need to change something right now in your visit, or I need to go and talk to somebody before your next one, we're going to do that.
Sure. So so now we've kind of shifted a little bit to the idea of culturally competent care.
Yes.
So I'm going to ask both. I'm going to ask in primary care, what's that look like? And then in behavioral health, what does culturally competent care look like? So, and obviously it's a big subject. So just scrape the surface or give me an example of what that looks like in primary care for you and for our staff here, what we want everyone to make that look like.
Yeah. I think it goes back to what I was talking about, like having that cultural humility. I have sat through trainings and things where it's like, all name your people group here, folks do this. And it's just like, if you weren't going to think critically about it, you're like, yes, all people from that area of the world want this one thing and would like to be treated this way. Yeah. And so I think a big part of cultural competent care is like, one, does this realize like, let that person show you what their culture is and stuff, right? And
like ask.
Yeah, like literally ask or just pay attention, you know, like see stuff and like kind of be non-judgmental in that way. And then if if it is a culture that you know something about, like, again, check yourself or you wreck yourself. Because like I speak Spanish, but I'm not from a Spanish-speaking country. I do women's health. I'm not a woman, right? And what I am not going to do, for example, with a Hispanic woman, is make a lot of assumptions that because I just happen to have these skills, I know everything about being a Spanish-speaking person and I know everything about being a woman. But I think when you do learn about the cultures, is you need to learn what their experiences and where they're coming from. You know what I mean? Because I think it's just having that emotional intelligence and having that empathy of knowing that, for example, healthcare has not been great to women historically. So if I say, you're due for your pap smear, and you say, no, not right now, that I just let it be. And I'm not gonna be like, well, when are we gonna do it? It's like, calm down, But if it's been about 10 years, it's like, nah, but for real, you should get that checked out.
But then do you ever open up the conversation of like, okay, what's your hesitancy?
I think so. So
like,
for
do you
me,
open that up if it feels organic and allowed?
Yeah.
Right.
Yeah. I think, exactly. It's that point of feeling organic and loud. Because I've had some patients where sometimes we just have some real conversation about like, well, why not? And really to dig into it and it's because like, I think for physicians, NPs, PAs, whichever type of medical provider, one thing that's always stuck with me from med school is like that physical exam part. Right. And I think sometimes we think physical exam, for patients, you think, oh, well, when they put the stethoscope on my chest, it's to my heart or this or that. But one thing that has always stuck out to me from when I was first in training in medical school was like years and years ago when those docs did not have any cool test or imaging, like that's all you had. You had the history and a physical exam. And those folks were good. Like Sherlock Holmes was literally based off of a physician. And if you read like Sherlock Holmes' book and like, why was he so smart? Because he's just observant and he paid attention. That is like really what we should be doing with physical exam. To where even if I never put a stethoscope on you and I sit across the whole time, I should be able to tell a lot about you. And I think taking that same concept goes into like that cultural competency to just like sit and observe the behaviors, observe what this person's doing, how they present themselves in the world, how they dress to get an idea and understand that you don't know everything. And you need to listen to that person because too many times, whether it's like patients telling me themselves in the exam room, just talking about past experience or we see it all the time like online, I would say people's probably biggest concern with healthcare is that we don't listen. And we sit there and like, well, this was going like, no. And the truth is like, you don't. And I tell folks all the time, like, I'm really just a very special advisor to you. You give me the information, I advise if that would be a good idea or not. And then it's up to you to figure out if you want to do it. And if you don't do it, I just have to deal with that. And again, part of that is just with that cultural competency, that cultural humility is in allowing that person to teach you, because you mentioned family culture earlier, right? Because I am going to be sorely mistaken if I think that every 30-something-year-old black male that I have as a patient is exactly like me. Their family situation might be different. Their parents didn't divorce, or they, grew up in like a more wealthy neighborhood or a less wealthy neighborhood than I did, or and just really sit there and learning people. And so because I think sometimes when it comes to culture, we really mess it up by making it seem one size fits all. But it's really just acknowledge that everyone has their experience. And not all of it was great. And just keep that in mind. Be trauma informed. I honestly, and Jessica talk a lot more about trauma informed. I think that's what cultural competence just looks like. Just understand that they're not like you and that's okay. And you need to learn what they're like.
And none of us are really alike. Like none of us are like each other.
Exactly.
Right?
Yeah.
Like we've all got something. We all have trauma in some way, shape, or form, and it's going to look different. So what does culturally competent care look like in behavioral health, Jessica?
Sure. First of all, I'm going to start calling my doctor's appointments advisor appointments moving forward.
Love
and
that.
I can't wait.
Love that. It feels like college.
It feels like
speak to my advisor.
But don't you
my
feel
health
already more
advisor
comfortable to tell me what you need to tell me?
You're my health advisor.
Well,
depending what
I feel like I should bring a
advisor's
portfolio in though. Like it feels special.
Here's all my problem.
Like bring all the meds, bring everything.
Here's my
Absolutely.
carpet bag of fun.
Yes.
Advise me.
So when we think about especially behavioral health, right? One of the things we have to be really aware of is the assessments we're using. Who developed it? Why did they develop it? And when did they absolutely? And who did they use as a study group, right? So a lot of assessments, especially initially, were done with collegiate age white individuals overwhelmingly, right? And again, until recently, a lot more males. And so is this assessment applicable? Is this assessment actually saying and assessing for what we are looking for even? So that's probably a different podcast too, but we have to think about that from the get. Yes, exactly, right? We have all these ideas. But also, you are not allowed to diagnose somebody with a disorder simply because they present as different from you, right?
Mm-hmm.
Sort of a cheeky lay way I put this is like, you are not allowed to diagnose somebody just because you think they're weird. Okay?
Yeah.
Like that is not okay.
Sure.
And you really need to look at like, why am I understanding their actions as pathology, right?
Mhm.
Is it showing up in a pathological way? And so cultural competency, I work with a lot of individuals who are grieving. Grief is significantly tied to culture, right? And how death practices are observed, what that looks like. And so, I think a lot of times people can really get misdiagnosed with a mental health diagnosis or a disorder. And it's like, well, actually, this is a really appropriate expression of grief within this culture, within this family, within this location. And so we have to look at and make sure that we're not seeing pathology we're not seeing different as pathology.
Sure.
Right.
And I think too, because I kind of sat here and poo-pooed all the cultural education that you might get, but I think it's like, because you can't wrap up a whole culture in like an hour presentation or like one video training. Like, so I think also with culturally competent care, whether it's on the behavioral health or the medical side, is like, just go out and learn something. And by learn, I mean like actually experience it, right? Like, if you're trying to understand a culture from a country that's not this one, travel, see what it's like there, get to know those people. I think a very important thing as a physician, if you're going to take care of a community, if you can, you should live in that community. Because what we don't need is like you fly in from your mansion, take care of these downtrodden people, and then leave like, no, these are your people.
Right. Be among the people.
Exactly. Like, and like in that, and just me and then, and my mentors coming up like that, that was just like a big thing. Is like, like I said, like as a Spanish speaker provider that takes care of women's health, am I a Hispanic woman? No. But you know what I can do? I can get out there in the Hispanic community. I can be more involved with things, along with like women and women's empowerment, to really sit there and learn, and not just to say, well, I read this, but to be like, no, like I've got friends that, are,
I've talked to the women in my life.
Yes. And more than one.
Yeah.
More than one,
Sure.
right? Like,
Sure.
just taking, all right, what my wife has told me, my sister's told me, my friends have told me, this,
Right.
that, boom, what is this? And so I think that's the biggest thing too when it comes to like just culturally competent care. If you want to learn, don't wait for no book or nothing to tell you.
Sure.
Like you get out there, you get in the field, and you get that lived experience. You see what people are going through. Because if I never even seen where your shoes have tread, how can I understand what it is to maybe even walk in them?
All right. And so while there is no bad time, and sticking in the behavioral health vein, there's no bad time to seek help. What are the benefits of being proactive or seeking help early?
Sure. They're manyfold, right?
I'm sure.
Because again, it's so much easier to treat at an earlier intersection. Because if we even just think about any sort of disorder or illness progression, right? If we catch something really early, it's easier to contain it, right? Sure. And I think about this a lot, right? I think it might be going a little in a different direction, but what is the fourth layer up from the Earth's crust called?
Is it people?
Okay, so see, thank you. Thank you for proving my point. Dr. Braye, would you like to take a stab?
Are we the upper crust?
Fourth layer?
Fourth layer.
We're above
upper
the transition
crust.
zone?
Excuse me?
Or are we above the transition zone?
No.
There's not one of those.
Like I know what I'm talking
Yeah,
about.
it's like I'm buying in, waiting.
Core mantle crust. Is it upper crust?
It's like mantle
crust?
transition.
Oh, is mantle transition? Okay.
I'm so close.
You guys,
wait,
honestly,
is mantle transition between the mantle and the crust?
This has really taken on a life that I didn't anticipate it.
Oh, well, I am literally envisioning my primary school science book. Like I have the vision in
So
my mind.
that's exactly my point.
Okay.
We were all trained. We were all taught on, okay, here is what our our Earth's
They
crust
may have said inner core,
like.
right?
Yeah.
But
Absolutely. But we all studied it.
Sure.
How many times have you been asked that question?
Oh,
I think
yeah.
today makes 2.
Yes, because you were there the last time I asked it, weren't you?
I love that.
Or maybe, are you talking not in school?
I do trivia.
So this is the third time.
Hardly
from time to
ever.
time.
I love this. Hardly ever. However,
Correct.
I always like to find a way to throw in a hot fact.
Absolutely. Okay, so here you go. You're welcome. And the truth is, it doesn't have a lot of impact on your daily life. Okay, if you didn't know any of those layers, honestly, you would live a very full life.
Yeah. And I also, even knowing that, I never walk around like I'm walking on the Earth's crust.
Yes.
Like that doesn't
I
happen.
know you will.
That's right.
I will now.
We're all thinking about it now.
Right now. Yeah.
And somebody out there is fact checking me. Okay, so I
No,
hope I remember.
Not a person. Okay. No
One of our
one.
degrees is in geology.
Full disclaimer. However, so that's not super important to your everyday life.
Sure.
Managing your emotions,
Mm.
managing your interactions with colleagues, peers, your loved ones, your medical providers, showing up in a way that you're able to effectively communicate with others, managing your stress so that it doesn't create and exacerbate other health concerns,
Mm-hmm.
super important.
Yeah.
And we are not taught it. Like if you think about health class, we all know the like food pyramid, right? Maybe we talked about Maslow's, but maybe not.
Y'all did?
Yeah.
Dang.
Hey, Benton County doing something right. Shout out. And so
She said.
and so it was one of those things, right? A lot of times we're not trained on coping skills.
Sure.
And so truly most folks are really farther down that development of a mental health diagnosis or a mental health disorder by the time they talk to a professional,
Mhm.
because we're not trained or we're not taught as humans, hey, there's this resource and it's okay to go access it as soon as you start to feel consistently like, man, I'm really worrying about a lot of things way more than I used to. Or I'm having a really hard time concentrating.
Mhm.
I'm having a hard time finishing tasks. Life just feels to be too much. And so we wait and we wait and we wait, right? If we, so the DSM holds all of my diagnoses, right?
What
all
is
of
that?
The Diagnostic Statistical Manual
Got it.
in its 5th edition, and it's been recently revised.
Ah.
There's probably a 6th on the horizon,
Oh, that's
I mean, always.
right? And so, very exciting. The, number 5, it was like, no, it does. I don't care. I was going to go into the colors. They're very fun. They come out with new colors.
You got to keep it fun.
Absolutely. And so we can diagnose somebody with an adjustment disorder. Okay, so adjustment, let's say that there is an individual and maybe like a pediatric patient and their parents are divorcing. And so they're experiencing more stress, right? But the symptoms haven't gone on long enough for us to diagnose an official disorder yet.
Mhm.
That's a really appropriate time for us to intervene.
Mm.
But that adjustment disorder can only be listed for 6 months. And so there has to be an improvement, and so a remittance of symptoms,
Mhm.
or we have to see progression of the symptomatology for us to give an official diagnosis.
Okay.
And so as early as possible, because there's so many effective modalities that we can use that are not years and years and years long, right? There's a lot of interventions and modalities that are even session specific. So we're talking like 6 to 8 sessions. So 6 to 8 hours over the course of 6 to 8 weeks,
Mhm,
right?
mhm.
We can see a ton of improvement just from that low level of intervention. And as with anything, it's always easier and quicker typically to treat sooner after onset as opposed to later.
Sure. Okay, awesome. Thank y'all.
Yeah.
Did you want to
I
add
would
to
say,
that?
And again, part of that is folks. It's not just folks reaching out, but us recognizing it, right? Because
Mhm.
before you get to the point that you're crying and you don't know why, it can be as simple as like, and again, when you have, your provider that knows you, just being like, "Yes, you all right? Like just don't look like yourself today. Like, you sure everything's okay?" And because actually, like, "Yeah, I'm fine. Like, I just was up all night with the kids." Like, "Okay," to like, "No, I'm not okay." Like, "Great, I'm glad I asked. Let's
Right.
talk about it." Let me text Jessica right now. But not in this scenario because Jessica was the patient. I'm going to text Jessica's team.
That's right.
And so, yeah, because like you mentioned earlier with social media and stuff, making it more known, the thing is, what gets views and clicks is the really dramatic stuff. So I tell my patients all the time, like when we're talking about bipolar disorder, it's like, the Walmart version of bipolar, this is what I say, if I ever got a little tiny mic to go through Walmart, be like, what does bipolar disorder look like?
Ooh.
People think like, oh, they just have mood swings and stuff like that
Sure.
and this and that. And it's like, and it's not. What it is like, you were kind of depressed. And then you had that great idea to start that dog walking business, even though you never had a pet a day in your life. And you're like, this could be the best thing ever. I already got it. And then you were like this close to like, really planning to move out to Chicago and launch your dog walking business. I was also going to have things in LA and New York. And this is the speed you were talking to with everybody about it. And everyone's looking at you like that. And then
You're like, okay, sounds
spend all
awesome.
the money. Yeah. And dyed your hair green. And then you realize like, I don't want to do that anymore. Now I'm sad again. That's bipolar.
Okay.
And sometimes it could just
Also
be,
extreme example,
yeah,
but.
Yeah.
But also, so I think because a lot of times folks are like mood swings. And so they think this really rapid cycling, right? So
Right.
like we're sitting here, everything's fine. And then I say something that upsets you and right now, right? And it's, again, this is more accurate. And I think that is one of our most important maybe charges actually is psychoeducation or education of our patients. This is actually what generalized anxiety looks like.
It's not
This
in the
is
moment
actually-
always.
Exactly.
Or
Yeah.
maybe
Right.
sometimes
Yeah.
ever,
Mhm.
Yeah.
right?
Well, and it's like, okay, so if we're talking about, I like to know, I like context, right? So it's
Yeah.
like, okay, if I'm talking about this population, what is the likelihood that this disorder, this diagnosis is going to show up?
Mhm.
So I'm going to look at that, right? I used to work in corrections. There's a very different skew of what diagnoses show up as opposed to primary care, as opposed to pediatrics when I used to work there,
Sure.
right? And so knowing, like, what is the likelihood here? But a lot of times it is the dramatic or squeaky wheel that gets the, the grease, right? And so it's like, oh, this, I'm thinking of a lot of like Patch Adams, right? Like
Okay,
these
yeah,
sort
yeah.
of displays where you're like, oh my gosh, it is all horror, right? And it's like,
Right.
well, no, actually that's,
Yeah.
Right.
Okay. So for somebody, what does that first visit, a first behavioral health visit look like at Carolina Health Centers?
So behavioral health visit proper or
Ooh.
Handoff.
absolutely. Are we
Or the
doing a warm
handoff.
handoff?
Well, let's talk about the handoff then.
Yeah.
And then also to begin that, if someone wants help
Sure.
and they want to maybe dip their toe in that and don't just want to come straight out and be like, hey, I need help.
Mhm.
But if they want to talk to somebody, who do they need to, how do they start that? And then
Sure.
what does that process look like?
So folks can come in for any reason,
Sure.
right? And so you just call whichever office of
My
ours that
toe
you go
hurts.
to. Absolutely, right? Or one that we, see a lot if we do a chart review, like from behavioral health, which we do a chart review, but like it may look like a like fatigue, right? Or something like that, that it's like, okay, well, do I have a virus? And it's like, well, no, it's major depressive disorder that you've had for years, right? And it's
Sure.
just very symptomatic right now. So folks can come in and they can call and schedule with their medical provider. And so if they call and schedule with their medical provider, Dr. Braye,
Yeah.
what is it going to look like?
Well, we're going with the fatigue one.
Yep.
Yeah, sometimes it goes through like, it might be in that first visit as I'm kind of going through like all the possible things. We do like the screenings. You talk about some of the questionnaires. But then a lot of times, folks don't usually, unless they've dealt with like mental behavioral health in the past, that won't be their first thing, right? It's like, I'm tired. It must be something I'm eating. Maybe I'm sick. Got the long COVID. I don't know, something like that.
Yeah.
And so for me, sometimes it's kind of like just kind of guiding to that point of like, well, Rachel, all your blood work came back great. Actually sounds like, well, shoot, I wish I slept as much as you. And and like everything else seems fine. Your diet's great, but I noticed that it seems like you're also been really stressed out. Like what's going on? And the way I usually started my own personal style is like, when, you say, instead of just being like, you have depression,
Right.
I just be like, honestly, just from the way these things line up and looking through it, like, I think looks like you might have depression. How does that resonate with you? Because I find that some people, when it's
so you
like,
drop the word and then you're like, how do you feel about that? Like, what does that make you? Where does that make you go?
Yeah, because some people be like, "Oh no, not that." Like, I'm fine. Like, seriously, like, I'm really enjoying it.
And so they're a tough cookie.
Yeah, no, or they're fine.
Or
like,
they're fine.
Yeah, and maybe
Okay.
it was wrong again because sometimes that questionnaire is just like, "Oh, actually, it turns out you have a newborn at home. That is why you answered most of those questions that way."
That is that. That is an answer.
But a lot of times for some people, they'll be like, "No, yeah, you're right. I think that might be it.
It could be a thing. Yeah.
And then
they're willing to explore that.
Yep. And then I lean to my Waffle House days as a server, and I lay out that menu, and I say, well, you know what? There's different ways we could go through that. It's it's
scattered, smothered, covered.
Yeah. It's like it's not just,
and that's where Jessica comes in, right?
No, yeah, it's not just medicine. It's like sometimes it's medicine, sometimes it's just like working on your life, getting through the stress, like maybe setting boundaries. And sometimes it's therapy, and I think therapy is great. And we have therapists like right here in the building.
Yeah,
it's not like I don't have to send you somewhere. Like we talk, I can she can come here and meet you right now.
Yep.
And if they're like sometimes like I don't know, and then I'm like, all right, well I could be your bootleg therapist until then, and usually they go with that, But then when they're like, yeah, that sounds great, I was like, all right, cool, just hold on right quick, and I just like send a little message, and then they come and I'm like, hey, this is Jessica, she's awesome. I would go to her for therapy if we didn't work together. I'll let y'all do your thing. I'll leave the room and then, and go from there. So it's kind of they meet that face. I'm introducing them. It's not like usual where it's like, here's your referral. 2 weeks later, some rando calls you. It's like, this is my person that I actually know.
Right.
And then I also highlight to them the strengths of integrated behavioral health. To be like, they're right here in the building. We talk over your case and really just like
you have access to the same information.
Yes. And I'm not pushing them off.
Sure.
We're just adding someone else into the team.
Right. No, we're just like, hey, we've just made your healthcare team.
But in a good way, yeah.
Yes.
But like we've just made your healthcare team bigger.
Yeah.
Right? And it's a nothing but for the benefit of the patient.
Exactly.
Right.
And so that is absolutely amazing. So what's your kickoff question? When you come in, what's your first question you ask a patient and like why? And not that maybe everybody has the same question, but your go-to.
A lot of times I come in, and it all depends on if I'm able to be introduced by the provider or if I'm coming in after they've kind of teed up an introduction. But even though a lot of times I'm able to do like maybe a really quick chart review, right? So I might see their chief complaint for today, right? Gotcha. Or I might see, 2 years ago, I see a clinician's name, so I knew, I know they're known to behavioral health, right? But when I come in, hi, my name's Jess. I'm part of the behavioral health team. Tell me a little bit about what's going on today.
Yep.
Because I'm not going to guide it necessarily. Now, it all depends, right? If I'm coming in because what we're concerned about is a really high risk situation, I come in very clear, right? Because some of that language actually is also validating and normalizing. Because the truth is, a lot of folks think about suicide, right? A lot of folks have really significant struggles, and there's no shame in talking about it. It's safe to talk about it here, and we're going to help you out, right? But if it's something where maybe it's someone who you've wanted to refer for a while, and they're finally open to meeting me. A lot of it, it's not about me.
You can't come in hot, right?
No. And that's really hard for me because I'm so excited. Okay, I'm ready to be here, right? And so I'm like, what is it that I could help with, right? What piece? And I go over what role I play, right? I'm part of the care team, and so you are still with Dr. Braye. We just are looking at, is there anything we can add to help with your health and wellness, right? Because it's not all pathology focused, right? I would love for folks to start coming to therapy because they're like, things are good, but they could be better.
Right.
And it's
or like I don't have the toolbox I want.
Yes, absolutely.
And I know something's going to happen because it's life.
Right. Absolutely. Yeah. And, even, public speaking for people oftentimes is really hard, right? And so it's like, I just want to be a little calmer. Yeah. I just want to be able to speak up and advocate for the things I love. And so can you help me? I notice my chest feels tight when I think about speaking in public. Like, is there something I can do about that?
And maybe something better than picture everybody in their underwear.
Yes, exactly. Right? Because that just is uncomfortable. Absolutely. No, you start smiling inappropriately and you feel weird.
It's not good.
No. Yeah. And so a lot of times it's more of like, hey, Dr. Braye let me know that today has been a little hard. How are you? And now I think a lot of times with behavioral health, like we're willing to sit and ask the questions that are uncomfortable, right? And so, because I have walked into the room and said, like, Dr. Braye has said things are a little hard right now. How are you? And I've had folks look at me and say, well, how do you think they are? And I'm like,
I don't know.
Not great. I would assume, right? And so sometimes, but that's okay.
Yeah,
because
sure.
I'm meeting them in that distress, right? And I think the thing that's really beautiful about behavioral health is like, there are no bad emotions. Some of them are just more comfortable to experience, right? And so like, I'm okay if you're angry. I'm okay if you're sad. I'm okay if you feel a lot of guilt over something. I'm okay if you're really happy. It's okay. Let's just talk about it.
Yeah. Awesome. Does anybody have anything else they want to add? I think we're hitting a wrap-up point for right now. For now. There will be more podcasts. So just to kind of summarize and cap end what we've talked about, from bunions to bipolar, if you haven't had a checkup in a while for your body or your mind, or you just want somebody on your side when it comes to your health, Carolina Health Centers is here. We are here all over the Lakelands. We've got 10 family medicine sites, 3 pediatric sites. We have pharmacies. That's a whole other thing to talk about, our pharmacy programs. And so we're here for you, body and mind. And we just, we want to be your medical home. If you do not have a medical home, we want to be your medical home and help build the healthcare team that you need, that's here to work for you. So we're care you can trust in your town. Okay. All right. Well, thank you guys. This is Jessica Jacobs, again, Director of Behavioral Health, Dr. Lance Braye, Director of Family Medicine, and I'm Rachel Manor, Director of Development here at Carolina Health Centers. And we thank you.